Hello. So now we're going to talk about co-management pearls for optometrists. First of all, I will say excuse me for using these kitschy slides. I just think they're fun. And if we're talking about pearls, I immediately thought of an Under the Sea theme. So this kind of 90s aesthetic is nostalgic for me. So first of all, just so we're all on the same page, what is co-management? And it's really a collaborative experience where everybody's winning. The first person who's winning the most is really the patient because the patient gets to kind of remain comfortable the whole time. So it's a model where the person who's seeing the patient the most, their primary eye doctor, has a discussion with them about their goals and learns that they would like to have a refractive procedure or need cataracts, discovers they need cataract surgery. So they send them to the ophthalmologist who treats them as a guest. So it's kind of like come spend some time at a hotel and then go right back to the person that's most familiar with your eyes. So the surgeon does the surgery, whether that's refractive surgery or the cataract, and then sends them back. So the primary eye doctor will see the patient for all the post-ops just like they are used to anyway. So they're really kind of a guest for us, and the person who knows their eyes the best does sees them the most, which, is a model that, intuitively really makes sense. It's great for collaborative care. And like I said, the patient is really the winner in that model because they get to, remain comfortable, come to, hopefully a fun place, get their surgery, and then go back to where they're comfortable with the staff and doctors that know their eyes the best. So now we'll just kind of talk through some co-management pearls and things to look for on exam for managing these different procedures in the kind of perioperative. So first we'll talk about EVO ICL. I cover all of these procedures in pretty great detail in a different video here. So we'll just focus on the post-op part and what is important to look for and what might not be as critical if you see. So first of all, the central port should always be visible, and in fact, it's usually the only tell that an ICL is even in the eye. The material is extremely clear, so when you're looking at the slit lamp, it honestly can be challenging to even see that there's a lens behind the iris at all. If you look in the middle of the pupil, though, there's usually that central port. It's just a 360 micron port so that the aqueous can always flow through. Because that port exists, there's no LPIs required. So if you might see patients with the historic legacy ICL called the Vizient ICL, that one does not have a central port, and typically there are two LPIs in the iris because, again, there's no central port, so there's no easy way or easy pathway for the aqueous to flow through the eye. So in the old days, we had to create a way for the aqueous to move so we didn't create any situations of things like pupillary block. Light pigment dusting is okay, and it's almost never visually significant. So this just means that there might be some pigment on the actual lens. That's just a product of the actual insertion and initial procedure of the lens. And different eye colors tend to release more pigment. And like I said, it's effectively never going to cause a problem. And it usually doesn't change over time either. So that's just something to not even worry about. If IOP is elevated, it's important to check angles. The ICL is sitting behind the iris and reduces the angle in the meridian that it's sitting on. But it's like a rectangle behind the iris, so it's only pushing the iris forward in one direction, and that's usually horizontally. The ICLs are almost always oriented horizontally. That horizontal orientation usually means that if you look vertically on gonioscopy, the angles are usually wide open, so it's just important to just check all four quadrants if the IOP is elevated. The IOP is usually the only time it's concerning with the EVO ICL is typically like immediately postoperatively, and we'll check that pressure 30 minutes to an hour after the actual ICL, and it's usually a product of retained viscoelastic, the OVD that we use during surgery to keep the eye stable. That usually will wash out by the next day, and then IOP problems are extremely rare with the ICL. Vault shouldn't change much and is much less important with EVO. In the other video, I have a graphic where I show how you can measure vault in your clinic just at the slit lamp without even needing to use the OCT or anything. But basically, if you offset the slit beam and the oculars at about 45 degrees, you can have a nice cross section through the cornea and through the center of the ICL to the crystalline lens, so you can kind of report it as a percentage of corneal thickness. So if you look and the ICL is about as far away from the crystalline lens as the thickness of the cornea, you can say, well, that's about 100% vault. It also, like I said, is a lot less important with the EVO model, and sometimes larger vaults are needed for larger eyes, smaller vaults are needed for smaller eyes, and it's something that we usually check on day one. Any refractive changes, their rotations are possible with the toric ICL, but extremely rare. One other important consideration with the toric ICL is, like I said, they're designed to typically be sitting horizontally. IOLs, on the other hand, have the toric marks near the haptics, so you can actually see where the lens is oriented, and it's usually oriented with the patient's steep axis and astigmatism. That is not true for ICL. When the ICLs are made, it's a very customized lens. On the actual lens, the axis of astigmatism can be placed anywhere there. So whether against the rule, with the rule, it is actually imprinted into the optic in a very specific orientation. So we might rotate them clockwise or counterclockwise, whatever is needed to line the axis up where we need it to be. But it's not actually, there are toric marks on the ICL, but they will not correspond usually to the patient's actual astigmatism. The company actually will send a report recommending, like, well, here's where the astigmatism is in this lens, so we recommend you rotate it like 5 degrees clockwise or something. So just it's important to know that if you dilate them and see that, well, it's horizontal, doesn't make sense with their prescription, it usually is okay because they're all kind of designed to be sitting horizontally. Rotations, though, are possible with the toric ICL, but they're very rare. The signs really include like a sudden increase in cylinder, and it's usually a mixed astigmatism that doesn't make sense with cornea if you have like topography or corneal topography. And it's like a sudden blurring of vision. It's really almost always spontaneous and really, really rarely related to trauma. The ones that I can think of that have happened over the past couple of years, it's really like I woke up one morning and the vision was blurry, or like I was just sitting minding my own business and the vision was blurry. So it's not like you can do cartwheels or rub your eye really hard. The lenses, if they're sized right, fit really snug in the sulcus space. So it's very rarely a concern that you can intentionally rotate the lens or manipulate the lens. The glare gets better with time, but may take weeks to months. So they might describe like concentric rings in their vision. That all will get better. I can personally attest, because I have ICLs myself. After about 3 months, the glare is really hard to see during the day. At night is kind of the perfect combination of things for the glare. It's dark, you have a pinpoint light source like a headlight, and as it kind of moves by, the rings kind of change size. It took about another honestly 6 months for the glare to go all the way away at night. After about 9 months, it's really was hard to see the glare at all, and now of course I can't even really make myself see it. So just explaining to patients, your brain goes through a process called neuroadaptation. It will automatically filter out the glare and halos as not useful information. So it's something that you just have to stick with, live your life. Don't go looking for them, and it'll go away. Another analogy I like to use is I say it's like your left shoe. You put your left shoe on this morning, but you haven't really felt it since because it's not useful information to send to your brain. So your brain just filters it out. Same thing with the glare and halos, and they will go away with time. The less patients think about it, the faster it resolves. ICLs really only need annual eye checkups and no special monitoring. We don't have to worry about tracking the endothelium, worry about checking pressure every couple of months. The EVO ICL is so safe that it's just nothing more than routine annual eye exams are really necessary. Next, we'll talk about LASIK. So on post-op day one, the big things to look for are vision. We expect both with ICLs and LASIK, we really expect 20/20 or even better for most patients. IOP is a lot less important and not something we usually check on post-op day one. We're also looking for any striae. There's two different types of striae. There's the microstriae and the macrostriae. So the difference is the macrostriae are the full thickness of the actual flap. Fluorescein is very helpful for checking these. If you see what looks like striae and you stain it and it's not really picking up stain, and then it's probably the microstriae kind and will usually resolve on its own over time or is not visually significant. If you stain it and it actually picks up the kind of wrinkles, sometimes called like skewed carpet, then it's probably the full thickness of the flap and probably macrostriae and probably needs to be addressed by the surgeon. If you do see macrostriae, you can ask questions about, have you been rubbing your eyes? One case I saw was, being a little too cavalier with the eye drop bottle and actually poking themselves in the eye, which could, dislodge the flap. Or the positioning of the goggles that we give at night so they don't accidentally, rub your eye in their sleep. Sometimes that can be malpositioned and like pushing up on the eye. I've seen that before as well. Also check for infiltrates or early signs of DLK. So remember, DLK is that like sands of Sahara appearance. If you do see any kind of infiltrate in the actual flap interface, you can consider increasing steroids. What you might see, especially towards the flap gutters peripherally, can occur, usually in the horizontally, so nasally or temporally. Actually having like meibum underneath the flap just as a product of the tear film can happen. It's usually like refractile and kind of shiny. It's like an oily substance. That's fairly common, especially if your patients have blepharitis or things. We do everything we can to treat that beforehand. But if that is in the interface or in the gutter, that normally just reabsorbs over time and is not a visually significant phenomenon. So DLK is usually like that sandy appearance where the meibum is just a refractile, oily appearing material. Subconjunctival hemorrhage is definitely normal. I wouldn't say it's super common, but the laser to actually cut the flap uses suction to hold the eye in place. The lasers we use are the most gentle available on the market, but not all the lasers out there are. Some of them use much more force with suction, and this can of course just rupture small blood vessels under the conj, so that is nothing to be alarmed about. Also encouraging patients to use artificial tears as scheduled, which we recommend 4 times a day, kind of in between the four antibiotic and steroid drops that we recommend during the day. And then the feeling of dryness, especially in the morning, is common and will definitely improve with time. Honestly, most of that kind of sandy feeling with LASIK happens that first night. We really encourage people to take a nap when they get home, go to bed early, which is usually easy because of the medications that we give them to help them relax, the Valium and things. But if you can kind of sleep past that first night, it's so much better the next morning. It gets even better from there. But we usually do procedures, if you do them on Friday, by Sunday, most of that irritation really should be gone. Going back to kind of the exam, so any fibers in the interface it's very rare also because you usually perform a rinse and monitor for things like that. But any fibers can be a nidus for DLK, so these should be monitored or irrigated early if necessary. And just, the surgeons are here for you as well. This is, like I said, it's a very collaborative effort of everybody working together. So any abnormalities of the flap, like striae, you see a fiber that you don't like, you see blood under the flap or something, or you think it's DLK, obviously let us know if you're concerned. But these things all respond really well to just early flap irrigation, before the flap is really welded down. It lifts fairly easily with the right instruments. It can be washed out. Things can be cleaned. And then they do really, really well. It's not even like a flap lift if it's that early. It's just kind of a re-rinse and irrigation, and everything looks really great. So PRK, as I mentioned in some of the other videos, should be like a minority procedure, something reserved for those times when all the other procedures are just not possible. So it's really like 10% or less of the volume of LASIK or SMILE, I would say, that myself and our group personally does. But for PRK, One recommendation to even before surgery is, considering vitamin C. So you can do like 1,000 milligrams or 500 milligrams in 2 doses. There's a limited amount of evidence out there to suggest that this can help with the recovery process and epithelial healing. Usually there's no post-op day one for PRK. There's, the whole epithelium was removed over the visual axis. So we normally place a bandage contact lens just for comfort. The epithelium just needs time to heal before the patient feels better and before vision improves. So there's really not that much to even see on day one. We normally wait for day 3 or 4 for that bandage contact lens to come off. And this is when the, kind of earliest that the epithelium would have healed over all the way. And when they will say, vision's better, less of that grainy feeling. Discomfort is expected to get better around this time too. If there's still really significant pain, typically blame an epithelial defect and it just hasn't closed in all the way. Dysplastic epithelium, it can look kind of heaped or abnormal. That's actually normal around day 4. If the epithelium is still missing in some sections or there's still a defect of some kind, just consider placing another bandage contact lens and following them. You can even, before taking the contact lens off, just kind of float the contact lens on a layer of fluorescein, and before even removing it, just looking underneath the contact lens to see if there's any fluorescein uptake on missing epithelium. Haze with PRK is fairly rare nowadays, especially because we use MMC and various techniques to reduce the amount of haze, like not doing PRK for large treatments. Haze usually appears between 4 days and 2 months, and it usually resolves spontaneously over just the course of routine postoperative steroid drops that the patients will be on anyway. Vision and refraction, though, it's important to kind of talk to people about, can really take 3 to 6 months to stabilize after PRK. So there's not needed to allow the patient to kind of get in their head and panicking if the vision and refraction doesn't seem like it's at the place they want it to be. If it's only been a month or so, it can definitely take time for the epithelium to remodel and normalize after PRK. Then we can talk about SMILE a little bit. One really cool thing about SMILE is it can be difficult to tell that SMILE was even done, especially once the interface heals. Really, the only tell for SMILE is the cap opening, which is just a very short incision that the laser makes to actually remove the lenticule. That's usually superior and underneath the actual lid. The vision can be actually better than the cornea even looks early on, and the interface can have a little bit of edema to it up to like a month after surgery, but vision is still actually usually excellent. Dryness, gritty feeling, sandy feeling, and what we call STODS, so surgical temporary ocular discomfort syndrome. Those are all very rare with SMILE, but patients still may report a little bit of that glare like they would with LASIK. With LASIK, it's just like LASIK, it's usually expected to improve over weeks to months. There's almost no need for even restrictions with SMILE just because the disruption to the surface is so small. Like LASIK, there might be that meibum present in the interface, and that kind of pocket where the lenticule was. That again just looks like oily, kind of refractile material. Very rarely, like slivers or pieces of the lenticule might remain in the pocket, especially if there was like a tear or something during removal of the lenticule. Usually, it can be safely observed because usually it's pretty peripheral, and if there's any suspicion that it's causing astigmatism or reducing vision, then definitely talk to the surgeon, and we can do topography or whatever, and see if it needs to be removed or something. Also, just like LASIK, it's important to look for any fibers. Fibers are very rare, but there are different steps during the cleaning process. So fibers can be a nidus for DLK, but DLK is exceptionally rare with PRK or with SMILE, thankfully. RLE, or refractive lens exchange, also something called lens replacement. We're really going to treat this very similar to a cataract. So it is essentially cataract surgery, just a little bit early. So the post-ops then are going to look identical to a cataract surgery. The only differences are the patients are going to be younger, And they're going to usually have higher expectations because they usually had received a multifocal IOL or some type of lens to get them some spectacle independence, which is why they got the RLE in the first place. It's typically a bilateral procedure, so we do both surgeries on the same day. And that means, the dilation really can last up to 24 hours. Sometimes we use extra dilating drops like 10% phenylephrine. Sometimes we use like intracameral medications like epinephrine or phenylephrine just to boost the dilation a little bit. So they can have, residual dilation for a few days, kind of depending on what exactly the happened in the actual surgery to achieve appropriate dilation to complete the procedure. Importantly, some surgeons use subconjunctival depots of a steroid or antibiotic combination drop, and this might look like a small area of hemorrhage or kind of elevated area underneath the bulbar conjunctiva. So it's important to kind of understand what the surgeon's regimen is. I can only speak for ourselves, obviously. So we do this, and it helps reduce the drop burden to just once a night for patients. But on exam the next day, you might see just a little elevation in the conjunctiva. Sometimes this looks like a chalky white substance if something like triamcinolone was used, or sometimes something like dexamethasone was used. So it's clear or slightly yellow tinge and might be really hard to see. The dysphotopsias are going to be, probably a more common conversation with RLEs than cataracts, and just because the use of multifocal IOLs. These resolve with time, and it's kind of the same conversations you have with ICL patients with the glare and halos from the central port. It's going to get better with time through neuroadaptation. It might take 6 months or even longer to get used to it, but just like everything else, the less you think about it, the faster it's going to get better. You don't want to chase it. You don't want to like stare at lights and switch eyes and see if you can make yourself see it. Just live your life. Let yourself forget it. Treat it like your left shoe, something that you're not thinking about. And before they know it, it'll stop being bothersome to them. There are a couple just things to emphasize with FLACS, which is femtosecond laser assisted cataract surgery, and just talking about cataract surgery in general. I will say, for us personally, all of the RLE patients will undergo treatment with the lasers, but that won't necessarily be true for whoever you're working with or for all cataracts. So for cataract, things, especially early on in the postoperative process, like day one, are to check for Seidel sign and look at the anterior chamber. You're going to see a little bit of Selin flare. That's normal. There'll be a little bit of edema in the cornea. That's normal. Usually around the main wound temporally. That's normal. And just check for any like residual lens fragments, things like that. There shouldn't be like an excessive amount of inflammation, certainly, that would make you think of like TAS or something. But like 2+ cell is fairly expected. Sometimes of course, the edema can vary based on how dense the cataract was. If the cataract was quite dense or white, or even those kind of dark brown, black, more Nagdian type cataracts, it takes a lot of energy to remove them from the eye. So a little bit more edema is expected, but this almost always resolves usually pretty quickly as well. So I mentioned OVD before, so that's just kind of the jelly. It's like hyaluronic acid really that we use to stabilize the eye. For example, when placing the lens in the eye, if you just tried to place an IOL in an eye without any type of infusion or support, it would just kind of collapse and everything would come forward. So we use the OVD to really stabilize the eye and create safe space to implant the lens and do various steps of the procedure. You might see some of that. It's a very clear substance, so it's just like a really very clear jelly coating the endothelium. That's very normal. That will wash out after a few days. Any IOP kind of elevation with cataract surgery usually is blamed on the retained OVD. But like I said, the anterior chamber overturns with aqueous every 90 minutes or so it doesn't take long for that to wash out. Any like late hyperopic shifts, you can consider OCT for cataract surgery, that Irving gas syndrome associated CME, just kind of pushing the macula forward. For things like persistent IOP elevations, edema that kind of won't go away, persistent macular edema, especially like sectoral corneal edema, it's not a bad idea to check gonioscopy to see if there's any kind of retained lens fragment sitting in the angle that could be irritating the lens and causing that persistent elevation. Sometimes pieces can hide during the procedure underneath the iris or underneath in the sulcus space. Obviously, we're all very diligent and do our best to remove every single piece of material, but it's possible very rarely things can get retained, and that's something to look for that inflammation. Any eye soreness after surgery is fairly common. Most of the time, the thing to blame is the speculum. So just using an eyelash holder, it's kind of a piece of metal, but it makes the surgery safe, makes it so the patients don't have to think about blinking. But it can be an uncomfortable thing that was kind of just in their eye. It's usually related to it feels like a muscle soreness. It's really common after any surgery, and that will go away after a couple days. Any transillumination defects of the iris could mean several things. It might represent intraoperative difficulty, like the iris was really floppy and wanted to come out. Sometimes using the rings can cause a little bit of the pigment to chafe off. So that's just another thing to kind of look in the notes with the surgeon about, and maybe have a conversation about how everything went. Usually not visually significant, though, I would say. So just for things specific to the femtosecond laser itself, so the femtosecond laser assists with, typically it makes the rhexis, so the opening in the anterior capsule to access the lens, usually softens the actual crystalline lens to make it easier to remove, so less energy is needed during the actual phacoemulsification part of the cataract surgery. And sometimes some use it to actually create the wounds, which is the main wound in the paracentesis too. And then oftentimes it is also used to create arcuate incisions. What this means is because it's being done with an extremely precise laser, the rhexis is very round, it's very precise. And you might even see little tabs on the rhexis. Those little tabs help tell us where the toric needs to be aligned. So these should match the toric marks on the IOL. Unless there was an intentional rotation of the IOL or something, the markings near the haptics on the actual IOL that indicate the toricity of the IOL should almost always align with those tabs on the actual rhexis. Another thing is the rhexis may not be exactly centered on the pupil. There's actually different settings that you can use with the rhexis. One setting I like to use is the centered to the actual visual axis. So this considers where the patient is looking, the anatomy of the capsule, and it helps kind of create nice centration of the IOL within the actual capsule, and that doesn't always correspond to the pupillary axis. Circumferential incisions that you see in the cornea, you'll see the main wound and the paracentesis, kind of depending on the handedness and the surgeon's preference. Sometimes the main wound will always be kind of dead temporal. Sometimes it will be kind of oblique or off to the side. That will just be surgeon preference, but you also might see the arcuate incisions. So the arcuate incisions are kind of circumferential, follow along in the mid-peripheral cornea, and those are the arcuate incisions for the astigmatism correction. They typically correspond with the steep axis and are usually paired, so if there's one on top, there's usually one on the bottom. The exception to being paired is if the astigmatism is at 180 or something, and it would have to be across from the main wound, and you wouldn't put one on top of the main wound, because the main wound will help a little bit too with relaxing the cornea in that direction. Subconjunctival hemorrhage is also very common with flax, just due to the gentle suction that the laser is using to hold the eye in place. Just like LASIK, SMILE, we have to keep the eye steady, especially for that very precise laser to do its work. So it has to hold on to the eye in some way, and sometimes it can just rupture those tiny blood vessels within the conjunctiva while doing that. Hemorrhage can also represent things like the depot of steroid and antibiotic, like I mentioned before. So these are all things that it's just good to learn what exactly your surgeon's regimen is during the cataract surgery. If they do the subconjunctival injection, or if they use the laser for cataract surgery, or things like that, and that will also inform what exactly to expect. So hopefully this is helpful, kind of helping you in the kind of perioperative time course of what to look for, what, is big warning signs, and what is kind of normal findings with these procedures. Co-management is really awesome, helps build really great relationships with not only the patients, because we kind of have now a mutual person that we both trust very well, who's going to be taking care of them and seeing them in the post-operative period. But they also get to be, so comfortable continuing to see, you or the eye doctor that they've been seeing like the most and who's most familiar with their eyes. So it's a really cool model. And, it's just a couple things to look out for in all these procedures, because they're all unique, and it's about having a good dialogue with your surgeon to kind of see their preference and their methods for things. So thanks for your attention, and we'll see you in the other videos.